The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Welcome to today's webinar, and thank you for joining us. My name is Kate Neal, and I'm the Communication Specialist at the Michael and Susan Dell Center for Healthy Living, and I'll be moderating today's presentation. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UTHealth School of Public Health in Austin. The center's vision is healthy children in a healthy world. Before we get started, I just wanted to make some housekeeping announcements. This webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. If you have any questions during the presentation, please enter them into your questions chat box. We will have time for a moderated Q&A at the end of this presentation. I'm excited to introduce our speaker today, Dr. Emily Hebert. Dr. Hebert is an assistant professor in the Department of Health Promotion and Behavioral Sciences at the UTHealth School of Public Health in Austin and is a member of the Michael and Susan Dell Center for Healthy Living. Her research focuses on the use of mobile technology for health behavior evaluation and intervention. She is interested in the potential for technology such as smartphones, sensors, and social media to improve research methodology and expand the reach of evidence-based prevention and treatment, especially among socioeconomically disadvantaged populations. I will now hand it over to Dr. Hebert to start her presentation titled The Future of Quitting, Emerging mHealth Strategies for Smoking Cessation.
Good afternoon, everyone. Thank you so much for coming today. I'm excited to talk to you today a little bit about my own research, which focuses on using mobile apps for smoking cessation. So I'll start by talking a little bit about the current state of the science, and then I'll move on to talking about where we're headed. So to start us off with some background, although rates of smoking have declined dramatically over the last few decades, cigarette smoking remains the leading cause of preventable death in the United States, causing more than 480,000 deaths each year. So currently, 13.7% of US adults are current smokers, and 4.6% of high school students reported smoking in the past 30 days. While youth cigarette use has been decreasing in favor of e-cigarettes, it's important to recognize that tobacco product use is started and established primarily during adolescence, and 90% of adults who smoke cigarettes daily first try smoking by age 18. So what that means is if cigarette smoking continues at the current rate among youth in this country, 5.6 million of today's Americans younger than 18 will die early from a smoking-related illness. So that means that smoking cessation remains a high priority goal for public health. The good news is that most smokers want to quit. So 68% of adult smokers said that they wanted to quit smoking, and more than half of smokers report having made a quit attempt in the past year. So specifically, 55.1% of adult smokers and 57.5% of youth smokers report having made a quit attempt. The other piece of good news is that quitting smoking can have a profound impact on morbidity and mortality, and the earlier you quit, the better. So these graphs are from the paper cited here from the New England Journal of Medicine, which examined the effect of smoking cessation on survival to 80 years. So what we see here is that for smokers who quit at 25 to 34 years of age, survival curves were nearly identical to those participants who had never smoked, meaning that if you quit smoking, you gain about 10 years of life compared to those who continue to smoke. And while the amount of life years you gain decreases the older you are, even those who quit smoking by the age of 64 are still gaining 4 additional years compared to those who don't quit smoking. So current best practices for smoking cessation treatment are really centered on and acknowledge the fact that tobacco dependence displays many features of a chronic disease. So only a minority of tobacco users achieve permanent abstinence in an initial quit attempt. And in fact, fewer than 1 in 10 adult cigarette smokers succeed in quitting each year. The majority of users persist in tobacco use for many, many years and typically cycle through multiple periods of remission and relapse. It takes the average smoker between 6 to 7 attempts to successfully quit. So those numbers obviously can be discouraging, but it's important to realize that most quit attempts are unaided. For a multitude of reasons, most smokers try to quit cold turkey, but in fact, we have a large body of evidence demonstrating that we all do have effective strategies for helping people quit. So the best practices, the two main elements of treatment are counseling and medication. So reviews of smoking cessation interventions have demonstrated that individual, group, as well as telephone counseling, like you would see in a state-sponsored quit line, are all effective in increasing quit rates. And there's a strong dose-response relationship, meaning the higher intensity and the longer the duration of counseling, the better chance someone has to quit successfully. So with counseling, we've identified two main elements that are most impactful. The first is practical counseling, which involves problem solving and skills training. So that can include things like refusal strategies if someone's offered a cigarette, as well as coping strategies to help deal with cravings or triggers. The second element is social support. So there's no question that having a network of individuals who are supportive of a quit attempt, having people who don't smoke and don't offer you cigarettes, as well as having professionals who can help you recognize that this is an addiction, also help the success of quit attempts. Then the second line of treatment involves medication. And under that, I'm including both nicotine replacement therapy and oral medications. So nicotine replacement therapy, or NRT, comes in multiple forms. Gum and patches are the most common, but it also comes in the form of inhalers, nasal sprays, and lozenges. NRT is available over the counter, but the oral medications like bupropion, which the trade name is Zyban for smoking cessation, and varenicline, also known as Chantix, do require a prescription. So bupropion acts on chemicals in the brain that are related to nicotine craving, and varenicline works by interfering with nicotine receptors in the brain. So both medications have also shown to be very effective. So you might ask, if we have good evidence-based strategies for smoking cessation, why do so many people fail? Well, the fact is that most quit attempts, as I said, are unaided, meaning most smokers try to quit cold turkey. So only 25% of US adult cigarette smokers reported using nicotine patches or gum during their most recent quit attempt, and only 15% sought help from a doctor or their health professional. There are a lot of reasons for this. Getting counseling or seeking out the advice of a healthcare professional obviously takes time that a lot of individuals don't have. And the unfortunate truth is that smoking disproportionately affects individuals with low socioeconomic status. So getting time off work to make an appointment is a challenge for a lot of smokers. Likewise, transportation is a commonly cited barrier, particularly among smokers living in rural areas. Then cost. Although a lot of health insurance plans, including Medicaid, do cover some tobacco cessation treatment, there's still cost involved, so like co-pays, medications, etc. And then finally, qualitative interviews with smokers trying to quit has revealed that a lot of smokers have misconceptions or doubts about smoking cessation treatment. And this could be in part due to the nature of smoking cessation, that it often takes several tries. And another possibility is that publicity about smoking cessation treatment isn't always good. So some of you may have heard or may remember in 2009, the FDA put a black box warning on Chantix because it was believed there was an association between Chantix and higher risk for neuropsychiatric events like depression or suicide. And that black box warning was removed in 2016 after more evidence showed that the side effects were really lower than previously expected. But a lot of patients we talked to have heard about those rumors and bring it up, and those kinds of misperceptions can linger. Now, it's important to note that all of these barriers are more burdensome among individuals of lower socioeconomic status, who already have higher rates of tobacco use and are also less likely to quit despite similar numbers of quit attempts. So obviously, improving access to smoking cessation treatments is an important step towards reducing smoking-related health disparities. And the good news is that mobile technology has enormous potential to overcome many of those barriers that we talked about from accessing evidence-based treatment. So smartphones, or in this context, when I say that, I'm talking not about flip phones, but about phones that can access the internet, are incredibly widespread in the United States. So 81% of all US adults own smartphones. And as I said before, smoking behaviors disproportionately affect people with low socioeconomic status. And the good news is that smartphone ownership is high even among those individuals. So specifically, 71% of adults with annual household incomes less than $30,000 report owning a smartphone. In addition, mobile health technology is becoming increasingly popular, and 21% of Americans report that they use smartwatches or fitness trackers. Also of note is that 62% of smartphone owners have used their phone in the last year to look up information about a health condition. So what does this all mean? What this means is that smartphones are a platform that is already widespread among diverse populations. So there's a lot of potential for addressing some of those barriers we talked about using mHealth interventions. So now I'd like to talk a little bit about the current state of the science with respect to mobile phone-based smoking cessation. The first type of mobile phone-based smoking cessation treatment is text messaging interventions. So text messaging interventions have been around for a while, and a recent Cochrane review found that text messaging programs could be effective in supporting people to quit with quit rates increased by 50 to 60%. So this was the case when they were tested as compared to minimal support. So text messaging interventions versus people just doing cold turkey, and also in compared to when they were in addition to other forms of stop smoking support. So here on this slide, I've highlighted one of the longer running and evidence-based text messaging interventions for smoking called Smoke-Free Text, which is a program developed by the National Cancer Institute. So for the Smoke-Free Text program, the user starts by signing up either by texting this number or by signing up online and entering their mobile phone number and choosing a quit date. So the user receives messages leading up to and following the quit date that they set. And they can receive up to 130 messages, some of which are bidirectional. So they allow the user to actually submit feedback. And it typically has three kinds of messages. So there's clinical content messages that are scheduled based on the quit date that they selected, and they increase in frequency the closer you get to the quit date, and they provide tools and resources to help with the quitting process. The second kind of messaging is assessment messages, and those are used to determine the user's mood and craving level and their smoking status. And after an answer is submitted, a message is sent based on the selection made by the user. So for example, if they're having a good day, they get a message with positive words of encouragement. And if they're having a bad day, they'll get a message with an actionable tip. Then the last kind of messages are user-initiated messages. So that happens when somebody submits a keyword based on a problem or symptom they're experiencing. So in the screenshot on the right, you can see examples. If they text the words crave, mood, or slip, they will get a message with an actionable tip that's tailored to that situation. So this is just one example of a text messaging intervention, but it has a lot of characteristics that are shared by text messaging interventions for smoking in general. They have the advantage of being very low cost and also really low effort for the smoker. But the disadvantage is that they're somewhat limited. So they tend to have limited responses because of their automation. And to put it kind of bluntly, they're a little old school. So this kind of intervention started before smartphone apps were really accessible. So they might lack the depth of content and the kind of user interface that a lot of people are now accustomed to from smartphone apps. So the next category is smoking cessation smartphone apps. So there are hundreds of publicly available smoking cessation apps. If you just search for quit smoking right now on the App Store, you'll see tons of results. I think the last estimate I saw from market data is that there are about 490 smoking cessation apps, which have been downloaded as many as 33 million times. So while the market's flooded with these apps, the unfortunate truth is that very few of them are actually evidence-based or empirically tested. So there have been several content analyses of iPhone and Android apps for smoking cessation, and they found that very few adhered to proven strategies like those best practices we talked about, like suggesting the use of effective medications or connecting to quit lines or clinics. Because of that, the same evidence of the effectiveness that we have for text messaging interventions don't yet exist for smartphone apps across the board. So that same Cochrane review, which was published in 2019, found that there wasn't enough evidence to determine the effect of smartphone apps. Now, one important takeaway from the research on smartphone apps is that content matters, but almost as important is engagement. So remember from the current best practices that the dose and intensity of counseling is important. So the effectiveness of apps is going to matter largely on how much someone actually uses the app. So here I've highlighted two apps that are actually evidence-based, one from Public Health England called NHS Smoke Free, and one from the National Cancer Institute called Quit Guide. Both of these apps have features that are actually rooted in health behavior theory, like journaling and self-reflection, so people can keep better track of their triggers and mood and behavior. And both of these apps also feature daily support messages. There's a savings calculator, so you can see how much money you're saving by staying quit. And a heavy feature across the board in smoking cessation apps are on-demand tips that help with cravings and other aspects of the quit attempt. So that means it's user initiated, somebody goes in and pushes a button, and they can scroll through various types of advice tailored to their situation. So I've given an overview of the main types of smoking cessation interventions that are delivered through smartphones, but there's a lot more to the current research on smoking behavior. Smartphones are also a really important tool in understanding smoking and the process of quitting. One measurement strategy that's become possible thanks to mobile technology is what's called ecological momentary assessment, or EMA. You're going to hear me say EMA a lot during this presentation. So EMA is also sometimes called time diaries or experience sampling, and it's a method using the repeated collection of real-time data on subjects' behavior and experience in their natural environments. It's been really popular within psychology research for the last few years. And what this means in plainer terms is basically frequent surveys delivered through mobile technology. So in a traditional survey, you might ask a smoker, in the last 30 days, were you around any other smokers? But with EMA, you have the ability to ask, right now, are you around any other smokers? So why would you want to use this? Well, there are two main reasons. The first is that EMA reduces the risk of recall bias. So one example of recall bias that we see with traditional surveys is the availability heuristic, which is a kind of mental shortcut that people make when making judgments about the frequency of events. So an event that comes to mind quickly, like a really recent event, is more likely to color your perception and your estimate than an event that is far away. So for example, if I ask you how many tobacco advertisements you've seen in the last month, and you just came from a convenience store where you saw a tobacco poster behind the counter, you're more likely to say, oh yeah, I see tobacco advertisements all the time, when in reality, you may only see them on the few occasions you go to a convenience store. With EMA, you reduce the risk of this kind of bias because you're not asking someone to summarize or estimate the frequency of events from a long period of time. You're asking about behavior that just happened or is currently happening. The other big benefit of EMA is that it's really ideal for dynamic behaviors and experiences. Most traditional surveys might be taken in a lab or in an office, but with EMA, you're gathering information in someone's natural context. So you're able to get a better picture of the social and environmental characteristics related to a behavior. So lots of thoughts and feelings related to behavior change from one moment to moment. So things like stress, you may be usually a calm person, but if you have a bad day at work or you have a stressful deadline, EMA is able to capture that variation from moment to moment. So there are two main sampling strategies for EMA. The first is time-based sampling, when a survey is solicited based on a schedule. So that can include things like daily diaries. So 30 minutes after someone wakes up, they get a survey pushed to their phone that they answer and talk about what happened the previous day. The other is surveys that are delivered at random time intervals throughout the day. So that's a strategy that we use frequently, is to have 2 to 3 surveys delivered at random during someone's waking hours. So we're able to program in a buffer so they don't get just 2 surveys back to back. And that gives us little snapshots about what they're experiencing during the course of the day. The other method is event-based sampling, where surveys are made each time a predefined event occurred. So in the context of smoking cessation research, something that's really common is you have a button that you ask participants to push when they smoke a cigarette or when they have an urge to smoke a cigarette. That's really useful because you are getting all kinds of information about what's going on in their head, what's going on around them, and what things are associated with the circumstances when they have a craving or when they're smoking a cigarette. The other type of event-based is something that's emerging, which is sensor triggered. So what that means is, instead of the participant pushing a button, it's something that happens automatically with the smartphone. So one example I've seen in a study is using GPS and geofencing triggers to initiate a survey. So if a participant, for example, says, "Oh, I always smoke first thing when I get to work," and you have their work address, the phone can automatically trigger an assessment when they get to work to say, like, what is your craving to smoke right now? What's going on? So with EMA research, we have learned a lot about smoking behavior that we wouldn't have been able to learn otherwise just with retrospective recall or traditional survey study designs. So the research has shown a lot of things that are kind of intuitive in terms of antecedents of smoking behavior. So obviously, if someone has an urge or a craving to smoke, if someone's stressed out, many smokers use alcohol. They smoke when they drink. Having cigarettes available is also a strong predictor. So one of the first things we tell people when they try to quit smoking is to come up with a plan that involves getting rid of your cigarettes. Also, proximity to other people smoking, proximity to tobacco retail outlets, and then of course having a low motivation to quit. So we've gotten this really good picture about what is going on when someone is trying to quit smoking. So that's led us to health behavior theories that are more focused on these kind of momentary situations. So one that we use a lot in our line of research is relapse prevention theory, which suggests that lapse events are immediately preceded by high-risk situations, and that an individual's coping response is the primary determinant of whether or not they'll lapse. So in this chart, you see at the top, if there's a high-risk situation and someone has an effective coping response, their self-efficacy is increased and they have a decreased probability of relapse. So that's one of the reasons with traditional gold standard smoking cessation counseling, one of the things we encourage participants to do is to come up with a quit plan. We ask them, what are you going to do if someone offers you a cigarette? What are you going to do when you're stressed out, when you have a craving to smoke? On the other hand, if somebody's confronted with a high-risk situation and they don't have an effective coping response, then it decreases their self-efficacy and their positive outcome expectancies. That can lead to an initial use of the substance, and then that leads to the abstinence violation effect, an increased probability of relapse. And the abstinence violation effect is essentially the I already ate half a box of cookies, so I might as well eat them all. So with smoking, it's like, well, I smoked one cigarette, I've already failed, I might as well smoke the whole pack. So that kind of theory has brought us to an emerging intervention design that's really specific to mobile health, called the just-in-time adaptive intervention, or JITI. And a JITI is essentially tailored support delivered in the moments when it's most needed. So it's attempting to provide the right type of support at the right time while eliminating support provision that's interruptive or otherwise not beneficial. So you're not just sending messages all the time, you're only sending messages when it's actually going to be useful to somebody. because they're adaptive, it uses dynamic information to modify the type, amount, and timing of support. So thinking of an example that you might be familiar with is the type of intervention that Apple Watches and other smartwatches utilize. So the watch is recording the steps taken, and after a predetermined amount of inactivity, you'll get a message encouraging you to stand up and take a walk. So that kind of intervention is just in time. So it's delivered in the high risk moment where you've been sedentary for a period of time, and there was a decision rule that led to that. So if you've been sedentary for X hours, then you'll get the message. If you were going to make that into a true Jedi by making it tailored and adaptive, the message might vary, for example, depending on your location. So if you're at work, it might encourage you to walk to the break room for a glass of water. If you're at home, it might know that you have a dog based on information that you give it and can advise you to take your dog for a walk. So obviously, this kind of intervention can be really powerful and has a lot of potential to provide something that almost mimics the kind of personalized in-person traditional counseling that you'll get. So that brings me to our body of work. So this was a pilot study that's an example of a just-in-time adaptive intervention for smoking cessation called Smarty, named for SMART treatment. It was an adjunctive smartphone-based smoking cessation treatment. And this was conducted by my postdoc mentor, Dr. Michael Busanel, who's at the University of Oklahoma Health Sciences Center. So in this pilot study, patients from a safety net hospital smoking cessation program were recruited, and they had a baseline smoking cessation program that included the provision of nicotine replacement therapy and counseling. In this study, participants completed EMAs 5 times a day for 3 consecutive weeks. So they completed EMAs for 1 week before their quit date and then 2 weeks after their quit date. And the design of the intervention was such that it used EMA responses to assess current risk of smoking lapse and automatically push tailored messages. And we had a weighted algorithm based on the presence of lapse risk symptoms to determine someone's risk. So based on the large body of literature and our own studies that we have, we kind of know what antecedents there are before someone starts to smoke. So we developed this algorithm that defined high risk by the presence of high urge, stress, cigarette availability, low motivation to quit, alcohol use, and interacting with others smoking, because those were the factors that we found were most predictive of whether or not someone was going to lapse during a quit attempt. So to give you an idea of the types of messages, the flow was that when a participant completed an EMA, we would use their EMA responses about their ratings for how stressed they were, if they were around other smokers, and so on, to determine if they were not interested in quitting, in which case there's no reason to give someone an intervention that's tailored if they're not interested in quitting. They would get a message in that situation that was focused on raising their motivation to quit. If the algorithm determined that they were at a low risk of lapse, meaning there weren't a lot of risk factors present, then they would get a generic message that was encouraging them to keep up the good work and to stick to their quit plan. But if they had a high risk of lapse, they had lots of factors present, then they would get a tailored message specific to the situation based on which of the strongest predictors were present. So we had messages developed focused on stress, urge, cigarette availability, and low motivation to quit. And we had a large library of hundreds of messages that would automatically be delivered once the mobile app determined that was the situation. So one example, this is a message that we had for stress, was don't let negative emotions keep you from a healthier life. When you feel stressed or angry, distract yourself, go for a walk, get out of the situation for a few minutes, try deep breathing exercises. And nowadays, you know, our new interventions are not just doing messages, it could be a video. Some of the interventions we do involve like meditation videos or strategies to increase mindfulness. It could be an audio file, that kind of thing. So looking at the results of this pilot study, we published a paper in Addictive Behaviors that were looking at whether or not tailored messages actually reduce smoking lapse triggers. So because this was a pilot study with no control group, we couldn't evaluate whether or not the intervention was associated with smoking abstinence because everyone got the same intervention. but we decided to look at whether or not the intervention reduced the smoking lapse triggers that they were designed to prevent. So we compared someone's rating of these lapse risk factors like stress before and after receiving the message. And what we found is that messages tailored to the situation, as you might expect, were significantly more effective in reducing lapse triggers than non-tailored messages. So this was really encouraging, and this led us to do a follow-up study, which is called Smarty 2. So the purpose of this study was to compare in an actual pilot RCT the feasibility and preliminary effectiveness of a smartphone delivered just-in-time adaptive intervention. So there were 3 treatment groups. There was usual care, the NCI Quit Guide app that I mentioned, because it was one of the few apps on the market that was actually evidence-based, and the Smarty 2 intervention. So all 3 groups, participants filled out EMAs and they received free nicotine replacement therapy. The usual care was standard smoking cessation counseling. The NCI Quit Guide and the Smarty 2 app both shared features of on-demand quit tips. But the Quit Guide, like I mentioned before, had journal entries and the ability to record triggers. And the Smarty 2 app had these real-time tailored messages. It also had gum reminders. So if somebody said that they had a craving to smoke, they would get an additional message saying, will you chew a piece of nicotine gum right now? Participants could also order new nicotine replacement therapy through the app. And it also had a button to call a counselor, which connected them immediately with the Oklahoma Tobacco Helpline. So we published these results recently in the Journal of Medical Internet Research. And what we found is that both app-based interventions, so both Smarty 2 and Quit Guide, performed at least as well as the traditional in-person counseling in terms of response rates, in terms of loss to follow-up, in terms of participant perceptions of the treatment, and engagement. And remember, with apps, engagement is really important to determining the dose of the treatment and its ultimate success. So I pulled out a chart here that I thought was a little bit interesting, looking at some of the participant perceptions of the treatment. So we asked them lots of questions about what they thought of the app, what they thought about their treatment, and we asked all 3 groups what they thought. So in referring to the app, they were referring specifically to the EMA app that was asking them questions. And we asked things like, did this make you more aware of your thoughts, feelings, and behaviors? So one thing that I thought was interesting is we asked the question, my treatment knows how to help me quit smoking. And as you would expect, the usual care group that has an in-person counselor, people really strongly agreed with that statement. What's interesting is that people also agreed with that statement in the Smarty group, but less so with the Quit Guide. And our thought was because the Smarty group is actually getting tailored messages that changed, unlike Quit Guide, there's a perception that the app is actually following their quit progress and is actually providing responsive feedback to them the same way that you would have with an in-person counselor. The other question we asked is, do you find the smartphone application to be annoying? Which is important because they're getting multiple assessments a day. I think we can all agree that if you're getting tons of notifications from an app, that can be somewhat obnoxious. And it's a concern for scalability of these kinds of interventions. So what was interesting is that the usual care and the Smarty groups did not rate the application as annoying as people in the Quit Guide group. So our hypothesis about this was that people in the Smarty group were actually getting an intervention delivered through the app. Whereas in the Quit Guide group, they had to answer EMAs separately, and then they had kind of the side Quit Guide app with the actual content, but content was really being delivered through the Smarty app. And so our hypothesis is that if people feel like they're actually getting a direct benefit from EMAs, they're less likely to find it disruptive or annoying. The other thing that was interesting about this study was engagement. So as I mentioned before, engagement with apps is really important. And we looked at the provision of on-demand content in this app and how people used it. So we had a library of a bunch of different messages categorized for different situations, like coping with stress. And we looked at the relationship of how many messages people accessed overall by the day of the study. And over the course of the study, most of the on-demand tips were viewed within the first 2 days of the pre-quit period. And then it dropped dramatically and then kicked back up on the second and third days of the post-quit period. So what this may suggest is that participants desire greater treatment content in the first few days after downloading an app and in the immediate period after the quit date, where stuff just got real, I'm trying to quit, now is the time that I need these supportive messages and need to help. This could also indicate that people were initially curious about the treatment content and then lost interest over time. So someone clicks the button and then they can click next to keep viewing messages. And what we were seeing with some people is that on day 1 or 2 of the study, they clicked through the entire message library of like 300 messages and then dropped off. So this is kind of interesting because to me, this tells you that it may be important to have tips or treatment content that becomes available over time instead of all at once. So apps like Quit Guide that just have that message available anytime may not be as effective for engagement as little drips here and there, like here's a new message today, not something that you can sit down all at once. Then looking at smoking cessation outcomes overall with this study, again, this was a pilot randomized controlled trial, so we weren't fully powered to detect statistically significant differences between these groups because we had a total of 81 participants. But what we saw was really promising. So 17% of participants were biochemically confirmed 7-day point prevalence abstinent at 12 weeks post-quitting. So in the Smarty group, it was 22%, in the Quit Guide group, it was 15%, and in the usual care group, it was 15%, with no significant differences across treatment groups. So again, this is a pilot, but what this says is that smartphone-based smoking cessation treatments may be capable of providing similar outcomes to traditional in-person counseling, which is really important and hopeful in terms of overcoming some of those barriers when most people are quitting cold turkey because they can't access evidence-based treatment. So what we've learned is that EMA is a useful tool to collect ecologically valid data about smoking behavior and experiences in real time. We've also learned that just-in-time adaptive interventions may be a promising strategy for health behavior change. But there are 2 problems. The first is that EMA can be burdensome and disruptive. So in all of our studies, we pay people to complete the surveys, the EMA surveys. So we typically will give compensation for completion of a certain percentage of surveys. But if we're going to scale this and translate it to be a public health intervention that we can disseminate to everyone, obviously we're going to have to solve that problem. The second issue is that the decision rules for when to deliver an intervention are typically static and based on group level trends. And I'll talk about why that's an issue in just a minute. So in thinking about these issues, let's talk about the future directions of where the mobile health smoking cessation treatment research is headed. So to solve the first problem, as I said, EMA can be burdensome and disruptive. So what we're seeing is a transition to using more passively collected data. So instead of using self-report, where someone is having to enter surveys 5 times a day so that we know about their circumstances, we're using, to the extent that we can, sensor data to replace that so we're not bothering people. So there's a growing body of research focused on the passive detection of smoking and smoking antecedents. So here are a couple examples. On the left is a program called AutoSense, which is designed to develop a wearable sensor that can detect impending stress. So it utilizes sensors like an accelerometer, galvanic skin response, which is kind of how sweaty you are. It also uses respiration. There's a chest band. And it's basically designed so instead of the participant having to tell you they're stressed out, you can detect these little micro changes and potentially deliver an intervention designed to reduce stress before it comes to the point where they might lapse. The other example here is a different kind. It's a wrist-worn sensor that is capable of measuring someone's gestures. So it's able to detect smoking gestures. And it's becoming sophisticated enough that it can distinguish between, say, grabbing a cup of coffee and sipping it versus using a cigarette, because the patterns are slightly different. These are some of the more complicated, like engineering focus attempts, but I will say that there are a lot of studies now that are utilizing um, more basic sensors like commercially available Fitbit, things that have heart rate or accelerometer just on your wrist. They're not doing anything fancy, but by tracking that passively collected data in combination with EMA, the hope is that we are able to look at the patterns and replace EMA self-report with passive detection. So this is something that I'm working on right now. I have a sub-study of an EMA study where certain participants are also wearing a Android smartwatch. So I'm collecting heart rate and pedometer, and I'll look to see how those features are associated with smoking lapse. Then the next issue I mentioned was that decision rules for delivering just-in-time adaptive interventions are typically static and based on group level trends. So you might ask, why is that a problem? Well, our research from EMA reports of smoking behaviors and lapse during a quit attempt have shown us that it's actually a big deal. We've done time varying effect models looking at the relationship between specific risk factors and the likelihood of someone smoking before and after a quit attempt. And what we found is that smoking lapse is highly dynamic. So these charts are a little bit intimidating, but the thing to look at is that we looked at each individual risk factor and the odds for lapse based on that risk factor over time based on the number of days from the quit date. And the thing to notice from these is that these are not flat lines. So what that means is that on day one of the quit attempt, it could be possible that urge to smoke is the single most important predictor of whether or not you're going to smoke. But by day 4, urge may not be as important. It may be stress. It may be drinking alcohol. And so knowing that smoking lapse is dynamic means that if we have interventions that are delivered based on a set rule of if this is present, we're not really delivering interventions in the moments when people need it, because time is really important. So the solution to this and where we're evolving is starting to use different analytic methods such as machine learning. So instead of a static linear algorithm to predict someone's risk of lapse, we're using machine learning. So machine learning is really all it is an application of artificial intelligence that's using computer algorithms to automatically learn and make predictions from large data sets. So the most common form is supervised learning, in which the program or computer is learning from training data to construct a model to make future predictions. So decision trees, one of the most widely used machine learning methods, are models in which a binary tree structure is used to represent a set of discrete decision rules. So here's one example. You may have a decision tree where you're not just looking at someone's momentary happiness, you're taking into account the fact that they're usually a happy person, but there's a change in happiness, and that's the factor that becomes important. So you may have a weight of different factors based on the presence of multiple risk factors. And as you can see, it's much more complicated than just sort of the simple, is there another smoker around? So the advantage with this is that decision trees are relatively fast to train. You can incorporate lots of different predictor variables, and it's really robust to missing values. But the main point with machine learning is that, one, it can quickly handle massive amounts of data. So now that we're starting to use sensors and passively collected data, and you have, let's say, continuous heart rate for someone, machine learning is equipped to deal with that. The second thing is that it's exploratory, and that's important because so many of our health behavior theories are static. We're assuming that a risk is the same across the board, but we now know that's not true. So with machine learning, it's sort of agnostic in that you can put everything that you've measured into the model, and machine learning will tell you what's important and what's not. And then finally, it can adapt to new data, which is nice because it addresses that dynamic nature of lapse. If it gets new information that, oh, this person is now no longer smoking when they're stressed out, they're smoking when there's another smoker around, this model is equipped to handle it. So that brings me to my own research, which is now focused on trying to create personalized interventions for smoking cessation using all of these factors we've talked about. So I currently have a grant from the National Institute on Drug Abuse, which is focused on using supervised machine learning methods to quantify personalized risk of smoking lapse, and then evaluate the feasibility of delivering a just-in-time adaptive intervention that's driven by that machine learning prediction. So the idea is that we're collecting a lot of EMA data from smokers, and we're having a machine learning algorithm kind of train on group level patterns, but we're also collecting pre-quit data. So the algorithm is learning what one individual's patterns are. So, for example, men and women tend to have different predictors for smoking lapse. Women tend to respond much more to mood, so stress and urge, whereas men tend to respond to more environmental factors like having cigarettes easily available. So this kind of machine learning model is capable of learning someone's individual patterns and then delivering an intervention based on that. So this, as far as I know, will be one of the first interventions to use machine learning methods to predict individual smoking lapse in real time. And the next goals are really to focus on how to scale this kind of mobile health intervention. So we know engagement with apps is a problem. We need to focus on reducing participant burden because unlike a in-lab study where you're paying people to complete EMAs, we need to be able to scale this kind of intervention that it's actually feasible, it's not disruptive, it's something that people want to participate in. In addition, the machine learning angle helps us reduce potential problems like battery life of devices. Some of those sensors that I showed you examples of obviously are somewhat cumbersome, and a lot of that is a limitation of battery size, of being able to collect intensive continuous data for that long. So the next phase of this research is really focused on making these scalable, yet trying to compete with the level of evidence-based treatment that you get from personalized one-to-one counseling. So I just want to quickly acknowledge my mentors, Dr. Busanel and Dr. Darla Kenzer, who did a great body of this work with EMA and smoking cessation interventions, as well as two of my collaborators, Robert Suchting and Matthew Kozlowski. Again, thank you to the Michael and Susan Dell Center for Healthy Living and the UT School of Public Health. And research in this presentation was supported by my K99 ROO, which is from the National Institute on Drug Abuse. And at this point, I will turn it over for questions.
Thank you, Dr. Hebert. We'll go ahead and take some time for questions now, so make sure to type your questions into your chat box. We do have one that has already rolled in. Dr. Hebert, are there any plans that you know of to test this on efficacy with vaping cessation?
Yes, absolutely. So the interesting thing is that we have tons of research about predictors for smoking lapse with conventional cigarettes, but there is just now a nascent growing body of evidence for vaping cessation. So before we can develop these kinds of interventions, we need to know what the risk factors are for vaping. And we hypothesize that they're not necessarily the same with cigarette smoking. People use e-cigarettes differently from cigarettes. They use them in different contexts. The puff patterns and things like that are all different. So our first step is to conduct EMA studies of vaping so that we understand the antecedents of vaping behavior. And then the next step after that would be able to develop just-in-time adaptive interventions that are targeting those decision rules based on what we've learned.
Thank you. We have another question here. Have you found that age is a factor for using smartphones or other devices?
Yeah, that's a good question. It is. If you look at the Pew Internet survey and research, there's no question that, like, very broadly, younger people are more comfortable with smartphone technology, but there's really widespread usage. I don't recall the exact percentage, but even among older adults and seniors, smartphone usage is still really prevalent. So it's definitely true that if you are targeting a specific population, one of the things we do is assess technological literacy, because we don't want to give an intervention to somebody for something that they're not going to use. So it is a consideration, but I also don't think it's as big of a deal as I think people intuitively think it is. The idea that older adults don't use phones or can't use technology, I really think is a myth. But that being said, it is something you want to consider. In any case, with just-in-time adaptive interventions, we're trying to tailor it to the individual. So their comfort with technology, the font size, things like that are all potential factors that we might tailor so it's more effective.
Interesting. And then are any of the data supported apps or text message systems free?
Yes, yeah. So the one that I mentioned, the NCI smoke-free text, is free. I'm happy to share that website after the fact. You can send it out to people. But if you just Google it, NCI Quick Guide or NCI smoke-free text, they actually have several versions of the smoke-free text program that are tailored for people who are pregnant and for veterans. So the messages differ a little bit, but those are free and accessible right now.
Great. Our next question is, have you observed an increase in hesitancy for these types of apps that some may perceive as overly intrusive?
Yeah, that's a great question. So the answer is no, interestingly. There is a body of researchers focused on mHealth that are very cognizant of the privacy concerns, especially as we get into starting to use sensor data and, like truly HIPAA protected data. So they're kind of best practices guidelines for how to conduct these studies in terms of delivering informed consent, having data security and protection, making sure participants are aware of how their data are being used. Me personally, like in our studies, we've had very, very few people who are concerned with that kind of thing. I think the novelty tends to outweigh that. And I think, I can't speak for all mHealth behavioral interventions, but I think that individuals that are seeking smoking cessation treatment, it is such a great benefit to have something that's with them all the time, that's easily accessible, that's something that's not just cold turkey, that they haven't had that hesitation. But that being said, it's a really good question. It is something that is on the mind of researchers that use mobile technology.
Okay. Our next question is, how do you biologically confirm smoking abstinence in your studies?
That is a great question, and this is a problem that we're doing right now. So traditionally, we biologically confirm smoking abstinence with exhaled carbon monoxide. There are nicotine test strips. You can test urine and saliva. There's also a blood test that can be used. We typically use exhaled carbon monoxide. And one of the challenges that we're dealing with right now with mobile health research is how to remotely biochemically verify smoking abstinence. Because if people still have to come to the lab, you're losing all the benefits that we've talked about of having it at your side, not having to have transportation or come in to see someone in person. So there are sensors being developed. There's one that we use in a study that is a small device that plugs into your smartphone that can detect exhaled carbon monoxide levels and report it in the app. And so one of the things we do is send participants home with that sensor, but we're also utilizing strategies like having the phone take a picture when they're blowing into it so we can verify their identity. There are video strategies where you call the researcher via Zoom or something like that so that you can biochemically verify. But we actually have a systematic review under review right now assessing all of the methods for remotely biochemically verifying abstinence. And so it's a growing body of research.
Interesting. That'll be fun to hear more about later. Our next question is, do you use motivational interview style questions for your survey?
In our assessments, we ask about, I guess we don't. However, there are several evidence-based smartphone apps that do use that. So I know Jonathan Bricker at the Fred Hutchinson Cancer Center has an app that uses some of those motivational interviewing strategies. A lot of the text message interventions get at that because they'll have reflection and response. Obviously, it's harder when it's automated. There are things like chatbots that can kind of mimic that. But in general, across the board, we do use theory-based. We'll consider, stages of change. We ask people if they're ready to quit smoking. And my mentor, Dr. Michael Businell, actually has a study ongoing that's actually targeting smokers that are not ready to quit to see if we can provide a mobile intervention that pushes them along that continuum. So that kind of gets at the motivational interviewing strategies.
Okay. We have a request if you could share the name of the sensor that you send home with participants.
Yes, so it's by the company called Bedfont, and it's called the ICO or the ICO device. They've just developed a new one, but if you look up Bedfont, it's BEDFONT, the ICO, you can see examples of that sensor.
Great. Well, that's all the questions we have so far. Is there anything else that you wanted to touch on before we end?
I don't think so. If people think of questions after the fact or have questions about mobile health in general, I'm very excited about this kind of methodology. I think it has broad applications to other addictive behaviors, not just smoking, but as someone said, vaping, opioids. So please don't hesitate to reach out if you have other questions or interested in collaboration.
Great, thank you. And thank you everyone for attending today's webinar. We appreciate you being here. This webinar will be archived on our website at msdcenter.org, hopefully later this afternoon, definitely by tomorrow. Thanks again for joining us today. We'll see you next time.